Hi everyone, welcome back to GreenGP. Tonight I'm going to give a bit of an overview of the menopause in general practice. So the definition of menopause is the permanent cessation of menstruation from the loss of ovarian follicular activity, and it's actually a retrospective diagnosis after there's been 12 months of no periods. The mean age of onset is 51. And it can range from sort of 45 to 55 and sometimes younger, which would be termed early or premature menopause. The symptoms of menopause are many and varied and can be quite vague, and it's important if someone presents with symptoms that could potentially be related to the menopause to think about some of the other possible causes as well. 85% of women actually report experiencing symptoms relating to the menopause, with a mean duration of the symptoms of just over 5 years. The estrogen deficiency associated with menopause results in two main types of symptoms, vasomotor and urogenital symptoms, and they're listed there in the table. In the longer term, the lack of estrogen is also associated with an increased risk of osteoporosis and also cardiovascular disease. In assessing women who present to their GP with complaints possibly relating to the menopause, most commonly this will be hot flushes. It is important to use this opportunity to perform a general health and cardiovascular risk assessment, as well as checking for other possible causes of the woman's symptoms, as I mentioned. It's a good idea to screen for various preventable diseases, which is a hugely important task for women at middle age in particular, including screening for breast cancer, cervical cancer as an ongoing thing with the 2-yearly pap smear, diabetes and cardiovascular disease, as well as possibly osteoporosis, depending on indication. As for all patients also, it's a good idea to go through the SNAP lifestyle questions with all women, so that's the smoking, nutrition, alcohol and physical activity questions. However, it's not routine at this stage in a woman's life to check the reproductive hormones like LH, FSH, estrogen and progesterone, unless a woman is thought to be going through early or premature menopause. When discussing management options with women at the perimenopause, it's important to know if they are symptomatic or not, and if so, how much of an impact these symptoms are having on their day-to-day life. It's also important that if a woman presents symptoms thought to be related to menopause, that you think about things like thyroid disease, depression, diabetes and other possible causes of the woman's symptoms. And therapy for symptom relief can then be discussed, and it could be hormonal and or non-hormonal. And I like to discuss all these possible options with my patients and not just jump directly to hormone replacement therapy. So I've listed a few of the non-hormonal options for treating hot flushes in particular. And however, despite these treatments, most women will find that the hot flushes are still reasonably troublesome, and the most effective treatment has been shown to be hormone replacement therapy, as you can see from the figures on my slide here, which were taken from the Women's Health Initiative study. So 767 women out of 1,000 over 5 years had improvement in their hot flushes compared to only 300 with clonidine or Effexor, and interestingly 530 for placebo only. So here are just some of the main benefits and risks that have been found in studies with hormone replacement therapy, particularly again the Women's Health Initiative study. And it is most helpful, HRT is most helpful for troublesome hot flushes and not so much for the other symptoms of menopause. It is used for symptom relief rather than for disease prevention. And before commencing women on HRT, it's really important to have that risk-benefit discussion with them. And I tend to point women to the Jean Hales Foundation website or the NH&MRC handbook for a bit more information so that they can have a read in their own time and potentially come back to discuss it with their GP again. If HRT is being considered, there are certain contraindications to consider. For instance, certain cancers, unexplained vaginal bleeding, which would need to be sorted out before commencing HRT, heart, liver or cerebrovascular disease, and the thromboembolic risk. The type of HRT chosen will depend on whether a woman still has her uterus or not. If she's had a hysterectomy, she can have unopposed estrogen only HRT, which will be continuous in either tablet or patch form. If she still has her uterus, however, she'll need to have combined HRT with both estrogen and progesterone. If it's still within 1 to 2 years since her last period, or she's still having some periods, the HRT should be cyclical, and contraception actually needs to be addressed as well, because HRT is actually not sufficient for contraception. If it's been over 2 years since her last period, then continuous combined HRT is appropriate so that she doesn't have to have a withdrawal bleed or a period. For predominantly urogenital symptoms, however, there's no need to use systemic HRT in most cases, and a topical estrogen may be sufficient to help with those symptoms. Many women in general practice seem to be on HRT for many years, perhaps because the discussion about stopping HRT hasn't been had with the GP. Suggested that the need for HRT be re-evaluated with a trial off therapy every 1 to 2 years. They're my references for today. Thanks for listening. I hope you found this a helpful overview of menopause, which might help you in your practice.